LRG Healthcare is a 2-hospital system located in central New Hampshire. In considering ourselves a referral center, we want to have beds available for acute patients that need those beds. And so we find as a community that there are times when we're loaded up with readmissions that we have to send acute patients and acute community members out of the system. Even a 5% readmission rate was not where we wanted to be.
Admissions are difficult for a patient because, frankly, if they have a chronic disease, every time they have an admission, it's very difficult for them to come back to baseline again. And for some diseases, they really don't come back to baseline. They get worse. And then ultimately, from the provider's perspective, we've got a limited number of providers in the community. So if one person is appearing over and over again, they're utilizing resources from a provider, and ultimately, at some point, as a provider entity ourselves, we have to say, what difference are we making in this person's life so that they can return to a good place of function?
When people leave the hospital, they get lost. And, they're sent home with this paperwork, and it has all these, abbreviations. They have no idea what that means. And people without a little bit of guidance in a really vulnerable time don't necessarily advocate well for themselves. And so what happens is you go home with all of these orders for blood tests, and they want these workups and procedures and follow up with this doctor in 10 days and this doctor in 12 days. And even though it's really concise and written out, it can be really overwhelming. A lot of the people I work with don't have primary care doctors, don't have insurance. And so what is really big is getting people connected to those services on an everyday basis, so it's not always crisis in their life, it's not always an emergency.
So they come home, but they slide back into their old patterns. They don't pick up the medicine, or they forget to take it, or they're on a different sleeping pattern than they were in the hospital. They're not waking up at 7 o'clock with breakfast. They're waking up at 9 o'clock. They forget to take their inhalers. They can turn around and end up back in the hospital within a 72-hour period. And the hospitalization really didn't accomplish anything. So now, what happens differently is before the patient's discharged, the VNA is called. We get the med list. Sometimes, if we're lucky, we get to meet the patient in the hospital and talk about what got you in here in the first place. And we try to find out who's a supportive person in that household that we can use to help remind them, you've got to take your inhaler. This isn't a maybe. You've got to do this. So now I think what has happened with Lakes Hospital is the Boost project has given them tools that really increase their communication throughout the hospital networks and beyond the hospital walls.
We got involved in it as one of 24 hospitals who were in the second cohort to implement Project Boost. We identify who's at risk for being readmitted. We look at putting interventions in place to mitigate their risk of being readmitted, and then implement those, do follow-up phone calls to our patients within 48 hours to identify what's happening, how are they doing at home. And also make sure that they have an appointment with their primary care physician within 7 to 14 days.
My role as a care manager is to start thinking about discharge as soon as the patients come in. So we first do an assessment of where they've been living, what kind of support systems they've had, what do we expect them to have when they're discharged from the hospital for supports. We look at what are their different illnesses that might precipitate a readmission. In our Boost rounds, we're talking together and sort of brainstorming with nursing, the people from ServiceLink, certain other disciplines within the hospital as to what they're seeing with the patient and what they might need, because they may tell the care manager one thing, and we may find out from the physical therapist that that's not really the case. And so ServiceLink comes in and can start getting to know the patient, start to review the needs of the patient, and begin work before the discharge day happens.
The pharmacy itself is involved in a couple of different areas. When patients come in, we kind of try and make sure their medication lists in the hospital are matching what they're taking at home. Then the second thing we do is when they're about to leave the hospital, any meds that they were started on in the hospital that their insurance company may require them to have a prior authorization, or there might be issues in getting like a rare medication. We try and help them find them in the community itself.
So I worked with a gentleman named Edgar, and he was someone who needed long-term care through Medicaid. And so I had been introduced to him in the hospital and had been able to meet with him and his wife and his granddaughter. And so we all sat down and spoke about what Edgar would need in order to stay home.
And she was very good about helping me get on Medicaid, yeah, and to help keep him at home.
And Beverly had been really happy with the service here at the hospital and with the connection that I had made with her in transition care. And so when he passed away, she said, "So does this mean I can't call you anymore?" And of course you can call me, please do. So then I met her in her home a few times, and we just went through and made lists of what's most important to happen first for you, and are you taking care of your own health now? Are you taking care of your own mental health now? It's a really difficult time.
But I never could have got through this without Sarah and ServiceLink and the visitor nurses and hospice.
It's better for patient satisfaction, it's better for staff satisfaction, it lowers staff turnover, it lowers costs. There's not much of a downside except for all the work you have to do to set something like that up, but it's so much better than the old way of doing things.